Good afternoon. We're here at ESMO 2024 in Barcelona, Spain. I'm here with Dr. Vadim Koshkin from the University of California, San Francisco, who presented earlier today on a phase 2 trial of futibatinib plus pembrolizumab in platinum-ineligible, untreated metastatic urothelial carcinoma. Welcome, Dr. Koshkin.
Thank you.
Thank you for joining us. Can you tell us a little bit about the phase 2 trial you presented earlier today?
Absolutely. Great to be here, and thank you for having me. Perhaps I'll start with a bit of background. So there is preclinical rationale for combining FGFR inhibitors and immune checkpoint inhibitors in metastatic urothelial cancer. There are also already studies that have reported data on that, such as the Norse study of combination of erdafitinib with citralumab. The motivation here was to investigate a different FGFR inhibitor, perhaps a better tolerated FGFR inhibitor, and maybe in some ways potentially more effective as well, known as futibatinib, in combination with pembrolizumab. So this trial, as you summarized already, enrolled patients who had metastatic urothelial cancer, were treatment naive in a metastatic setting, and were platinum ineligible. This was a global trial across both North America and Europe, 3 countries. It enrolled patients into 2 cohorts. Cohort A included patients with FGFR3 mutations or FGFR 1 through 4 fusions. And then cohort B included either wild-type patients or patients with other FGFR alterations. So that was another distinguishing feature of this trial relative to some of the others, in that it did test an unselected FGFR cohort as well for this combination of FGFR inhibitor and an immune checkpoint inhibitor.
What was the rationale for including patients, unselected patients, as you mentioned?
Yeah, that's a great question. So again, there is some preclinical data that FGFR inhibition can perhaps make tumors more susceptible to immune checkpoint inhibition as well. So in other words, make cold tumors hot, lead to increased T-cell infiltration. And so that was the main rationale behind that, and really to test whether there is a real signal there in that setting as well.
And can you tell us about the results in both cohorts?
Absolutely. So cohort A, so overall I should say the study enrolled 43 patients. Cohort A, that's the biomarker selected cohort, so to say, included 17 patients, and the remaining patients were in cohort B, and that was 26 patients. There was also, I should say, because this is the first time this combination was investigated in human patients, that there was a 6-patient safety lead-in, but that was biomarker unspecified, but all those ended up being actually in cohort B. So starting first with cohort A, that's again the biomarker-defined cohort with FGFR3 mutations and FGFR 1 through 4 fusions or rearrangements. Their response rate was about 47%. And so that's due to the combination of course, futibatinib and pembrolizumab. Time to first response was about 2 months. Median duration of response was about 12 months. So these responses were durable. Important to note also that responses were seen both in patients with FGFR3 mutations and FGFR 1 through 4 fusions. So specifically FGFR 2 and 3 fusions are the patients that actually ended up being included and where we saw activity. Median progression-free survival in cohort A was 8.3 months. Median overall survival actually was not reached after median follow-up of about 18 months. Now switching to cohort B, that's a cohort that included mostly wild-type patients. Their response rate was more modest. It was 47%. I should say 27%, unlike the 47 in cohort A. Median progression-free and median overall survival were about 4 months and about 18 months, respectively. Responses in that cohort were durable as well, about 14 months on average. Those were the larger kind of outcomes of the study. Again, these were non-comparative cohorts, but as we see in the biomarker defined cohort A, responses were higher, potentially more benefit in that patient population.
And were there any findings that surprised you?
I think overall these results were fairly consistent in terms of the activity of the combination to similar combinations in prior trials. So looking at the Norse study for reference, for instance, I think the numbers are pretty similar in terms of both the response rate, which is certainly within the confidence interval of this study, and then also the median progression-free survival also within range, duration of response also approximately the same. So in that sense, I would say it was pretty consistent in the mostly wild-type cohort B, the unselected cohort. The outcomes we see are essentially what you expect with a potential checkpoint inhibitor monotherapy. So response rate in the high 20s, potentially longer overall survival actually than we've seen in prior studies of single agent checkpoint inhibitors. But again, those trials were from a different era, and of course, in general, comparison across trials is fraught. So no, I mean, I would say this is about, consistent with what I would expect.
And where do you see further development of this regimen?
Yeah, so that's a great question. So this is a smaller phase 2 signal finding study, right? And so it does suggest that there's clinical activity of this combination of futibatinib and pembrolizumab in biomarker selected patients. But it was designed in a very different era, and a very different era nowadays qualifies as just 2 years ago, right? So the trial was designed a little bit before that, of course, in that it enrolled mostly 3 to 5 years ago or so. And so at this point, due to the significant shifts in the landscape of urothelial cancer, the landscape looks very different, right? Most patients will be probably getting IO, not just in the metastatic setting, but potentially even earlier. The Niagara study will actually be presented later today, and that will potentially shift that landscape. So most patients, so this patient population included in the study were really treatment naive patients who have not seen a checkpoint inhibitor, not really seen other systemic therapies in the advanced setting. We won't be seeing that probably too much anymore. Patients would have already been exposed to other therapies. So I think, potential thoughts about investigating this maybe in the post-IO space, so kind of looking at this combination, or even thinking in completely different settings. So maybe earlier.
Setting?
Yeah, perioperative setting, or even earlier perhaps, like non-muscle invasive, right? Where actually there is even the prevalence of FGFR alterations is enriched.
Right, especially in upper tract. So.
Yeah.